All right, so let's go ahead and get started. Um, Welcome, everybody, to the University of Washington Department of Medicine's Grand Rounds. My name is Shiv Bhandari. I'm one of the inpatient chief medical residents at Malt Lake, and excited for today's lecture focused on diversity, equity, and inclusion. We have two speakers today, and I will be monitoring the chat for questions. Please do send questions via the chat. At the end of both of our presentations, I will read them out loud. Here to introduce our speaker is Dr. David Horn, who is an associate professor in the Department of Pulmonary Clinical Care and Sleep Medicine, adjunct professor in global health, and also the associate chair for diversity, equity, inclusion within the Department of Medicine. So without further ado, I will turn it over to you, Dr. Horn.
Thank you, Shiv, for that introduction. And welcome to the annual Department of Medicine Diversity, Equity, Inclusion Grand Rounds today. I'm so pleased that today we will be hearing about the efforts of two of our own DEI heroes who have brought their passion, creativity, and resilience to advancing DEI at UW. So I will introduce both of them, and then we won't have space between their talks, but at the end, there will be time for questions that Shiv will moderate that can be directed at either or both speakers. So first up is Dr. Lorena Alarcon-Casas Wright, who is a clinical associate professor in the Division of Metabolism, Endocrinology, and Nutrition here at the University of Washington. Dr. Casas Wright was born and raised in Mexico, where she went to medical school at the Universidad Veracruzana in her hometown before migrating to the United States, where she did her internal medicine residency in Santa Barbara Hospital, which was affiliated with USC, and her endocrinology fellowship here at the UW in Seattle. Dr. Wright's interests are in diabetes care, with a special emphasis on cultural aspects of care and in underserved populations. Dr. Wright is the founder and director of the UW Latinx Diabetes Clinic within the UW Diabetes Institute in Seattle, and she chairs the Equity, Diversity, and Inclusion Committee in her own division and is a member of the UW Department of Medicine Diversity Council and a DEI champion. Dr. Wright is also passionate about delivering gender hormonal affirming care to gender diverse individuals. Following Lorena, we are going to hear from Dr. Jason Deen, who serves as the Vice Chair of Equity, Diversity, and Inclusion in the Department of Pediatrics at the University of Washington and directs the UW Medicine Center for Indigenous Health. Dr. Deen is an Associate Professor of Pediatrics and Medicine in Division of Cardiology, and he is the incoming chair of the American Academy of Pediatrics Committee on Native American Child Health. Jason actively mentors Native pre-medical and medical students, Native residents and fellows, and Native junior faculty. And as an MPI of the Strong Heart Study, Dr. Deen's research focuses on cardiovascular risk stratification in American Indian youth. So thanks to you both, and I'll turn it over to you, Lorena.
Thank you. Thank you so much. So I'm going to share my screen. And I think you can see it now, right? Okay, so yes, thank you so much for inviting me to talk about disparities in diabetes care and or Latinx Diabetes Clinic. First, I would like to acknowledge that we are on the traditional land of the first people of Seattle, the Duwamish people, past and present, and honor with gratitude the land itself and the Duwamish tribe. I don't have any conflicts of interest. However, I am Latina, born and raised in Mexico, and that probably very likely influences the way I feel about this topic. So I will, give you very, few slides about statistics. I mainly want to spend the time telling you about what we've done in the Latinx Diabetes Clinic. So I think that it doesn't come as a surprise, right, for all of us that diabetes is a huge public health problem. And most of us are aware that diabetes affects minoritized groups significantly more than the non-Hispanic white population. And this is to show you, this is national data that the populations most affected by diabetes are American Indian or Alaska Natives, non-Hispanic Black, and Hispanic community. The data in our state of Washington, is very similar with these three groups affected the most. The Hispanic community is the biggest and fastest growing minority group in the state of Washington. And unfortunately, along with this increase in size of the population, also the rates of diabetes and diabetes complications are significantly higher and disproportionately compared to the white population. Not only diabetes affects us Latinos, more severely. Once we have diabetes, then we tend to also do worse. The complications are more common. As an example, Mexican Americans suffer about 70% more kidney failures as a consequence of diabetes compared to non-Hispanic whites. Mortality is also significantly higher, and other complications secondary to diabetes are also significantly higher. Diabetes is also being diagnosed at younger ages in minoritized groups, not only the Latino community. Also, then I wanted to mention that most Latinos in the state of Washington are of Mexican descent. And I always wonder, right? Like I always wonder, being Latina, that when I would read about these statistics, like I always wonder why that is, that once we are, Latinos diagnosed with diabetes, we tend to do worse and so on. So then I think that's how my interest in diabetes disparities started. And this is, showing you some data about some of the measures that we have, like standards of care for diabetes. We all know, right, that we are recommended to measure A1Cs and to do food exam, dilated eye exams, and to monitor cholesterol in our patients with diabetes. And this is cross-sectional data in a medical expenditure panel. This is representative of the U.S. population. And you can see that in the Hispanic community, these tests are done, or recommended or done. The adherence for this test is significantly lower when we compare to other ethnic groups. When this data was adjusted for insurance and poverty and education, it changed significantly, but some disparities still persisted. Like, for example, A1C was still significantly different, significantly lower in Hispanics, Blacks, and Asians compared to white patients. And food exams was lower in Hispanic patients. Oops. Okay. All right. So this, shows that access to care is a huge barrier. Potentially, we can look at, that. But there are also other barriers that we cannot clearly identify. So I think that we all agree that diabetes outcomes in Latinx patients and also in other minoritized groups are partially due to healthcare inequities, like disparities in diabetes care. And this includes inadequate access to culturally sensitive healthcare. So that's how, we thought of this initiative, this clinic, like a clinic where we would specifically target this high-risk population, the Latinx community. So our clinic, the Latinx Diabetes Clinic, opened officially in November of 2020. And currently is Dr. Leo Morales in this picture, and myself, who see patients every Tuesday, and then we welcome patients with diabetes and pre-diabetes. So as I mentioned, I want to spend most of the time telling you what we've done in the last, less than 3 years. And because one of my hopes is that this can, inspire you, that the Latinx Diabetes Clinic can hopefully serve as a model to target other high-risk populations. So when I first thought about this initiative, the Latinx Diabetes Clinic, I focused on these 3 objectives, right? Like I felt that this would be like the mission of our clinic. And the first one was to decrease diabetes disparities by addressing linguistic and cultural barriers. But also, being in an academic institution, the University of Washington, teaching, like teaching our future generations needed to be also a mission of ours. And also that when having patients in this, clinic there altogether, right, like that hopefully would increase the opportunities for clinical research. So I'll tell you a little bit more, in each of these topics of what we've done so far. So when it comes to decreasing diabetes disparities by addressing cultural and linguistic barriers, our clinic provides bilingual care. Both Dr. Leo Morales and myself, we are bilingual, but we are also bicultural. Our team, this is part of our team. We aim at providing culturally appropriate nutrition counseling and diabetes education. She's Melissa Montalto. She is our nutritionist, and she is bilingual. And again, we strive to provide culturally sensitive guidance. This picture was taken when, like COVID was, we could not even take a picture without our masks. And this is part of our team. We also aim in our clinic to increase the access to technology and new therapies, because this has been an area where, diabetes disparities has been observed. And we also want to increase the referrals to specialized care when needed, like referrals to nephrology, cardiology, ophthalmology, or vascular surgery in a timely manner when this is appropriate. Our clinic, and this is probably what has resulted in the biggest changes or success of our clinic, is financial assistance. So our patients, our clinic provides financial aid to patients who don't qualify to any other program. So patients who don't qualify for Medicare or Medicaid or regularly, so then their care, they need to fill out financial assistance application and so on, but the care of the patients is provided. We do want to have a very close connection, with our community. So then we aim to partner at, with community organizations. And we participate in health fairs where we screen for diabetes, prediabetes, hypertension, obesity. These are some of the pictures that we've taken in some of the events. I think that is really important, that patients see us out there, or like at least in the Latino community, to feel this sense of familiarity and to get to know your doctor. It does make a huge difference. So then not only we are screening, for diabetes and so on, and providing guidance to patients who, we screen, they are positive for prediabetes, diabetes, or hypertension and so on, then we refer them or give the information where to go for care ourselves, right? Like in Spanish. So then we really encourage them why that is important, because we do want to that they have increased access to care. Okay, so then when it comes to the second objective, right, the second mission that I told you about, and that was to enhance the teaching mission of the University of Washington School of Medicine on cultural and sociological aspects of diabetes care. We currently have a clinical rotation for internal medicine residents and also for our second-year endocrinology fellows. Our clinic also provides many opportunities for quality improvement projects for trainees, or clinical projects to opportunities to present in conferences and so on. We also, with the help of Dr. Gino Eisenberg of the School of Social Work, we have developed a social work practicum for bilingual students of the School of Social Work. So we are very excited about that. And I just wanted to mention, some of the projects that our trainees have. These projects are ongoing. This is Dr. Ku. She is an endocrinology fellow, and she has looked at the use of telemedicine in our Latinx patients in our clinic. She has looked at Latinx and compared to non-Latinx patients in the use of telemedicine, and we found that telemedicine use is lower in Latinx patients compared to in white patients, and that also, age, not surprisingly, makes a difference. This project is going to be presented at the Endocrine Society this summer. Dr. Arita, who is an internal medicine chief resident currently, she also presented in the American Diabetes Association last summer. She had posted an oral presentation showing some of the data from our clinic on the use of continuous glucose monitors in Latinx patients with type 2 diabetes. And she showed that this technology is very well received by patients, and that it also results in significant improvements in glycemic control, because that actually had not been shown in Latino patients with diabetes. Our clinic, or Latinx Diabetes Clinic, also provides opportunities for talented international medical graduates to rotate, right, like to do an observership in our clinic. The goal of these observerships is that not only its international doctors get more familiar with the healthcare system in the US, but also for them to be involved in projects that will strengthen their CV and to make them more competitive in the US when they apply for a residency program. Lucia is now a resident in our internal medicine program. She did an observership in our clinic. Dr. Miramontes, he recently matched at in an internal medicine program as well. And Dr. Cairo, he is currently doing a rotation in our clinic, and he is a postdoc research fellow at the VA who is planning to apply for a residency program next in next year. Not only then these are opportunities for our trainees or for our students, but also we hope that with this, we are contributing to increase diversity in the healthcare system in the US. When it comes to the mission, the objective number 3 of the missions of our clinic, the third one was to improve the overall health of the Latinx community through increased clinical research. And I'll tell you a little bit about this. So we have a program. Well, this is it's called the Compañeros en Salud, which is like Partners in Health. This is a 12-module program. It is a bilingual program. It was created by Dr. Sinclair. And what this is these are the different modules, the different topics. These are classes that are given to patients. They're both in English and in Spanish. And the way these are like stories. It's a kind of a narrative to make it more interactive and more culturally sensitive. So to have like the engagement of the participants. We pilot tested this. And we showed that it does, that it did improve A1C and glycemic control in urban patients with type 2 diabetes, Latino patients. We use this program, these Compañeros en Salud, or Partners in Health, in these randomized control trials. So we recently, Dr. Urhar is the principal investigator. Our team recently published the protocol of this study. So this is a randomized control trial using the Compañeros en Salud, Partners in Health modules, the education in Latinos with type 2 diabetes, paired with a continuous glucose monitor, and then comparing with a group without CGM. I can't really tell you more about this because this is going to be presented. Some of our preliminary data is going to be presented at the American Diabetes Association, but we are very excited. And this program has shown that hemoglobin A1C was reduced by 2.7% in the group that was had CGM. It was also statistically significant in the group was not a match to, who did not use CGM. But this is just to prove that, when we have interventions that are specifically designed for the population at risk, that, like we see results. So, I can tell you, I can talk about this like forever, but basically what I want, to conclude is that when we want to, fight or address disparities, not only in diabetes, but in healthcare in general, we really need to adapt, right? Like we need to adapt our programs. We need to learn about our population that we want to target, and then have interventions that are specific for that population. Part of the problem has been that many of our interventions for diabetes have not been designed for the Latinx community or for other minoritized groups. So we really need to look better at providing bilingual and culturally appropriate care, not just for the Latinx community, but for other minoritized groups. We need more research, right, like on new methods of evaluating clinical, behavioral, and psychosocial aspects of health. We need to implement multi-level programs, really, from screening and promotion of prevention to for patients who are at higher risk, and then improvements in access to quality medical care to optimize provider and patient knowledge alike. So I will then conclude to hopefully, inspire you that, these interventions not only were very satisfying, but they are successful. So then to eliminate disparities, we must know enough. We need to learn, learn from our population. We need to do enough. We need to deliver the outcomes. We need to commit, right? We really need to care about this, and we need to persevere. So don't get discouraged. I really try to focus on the positives on this talk, and I will then stop here, and I'll answer questions, I think, at the end. Thank you so much.
Thanks for that great talk, Lorena. That was great. So Keenex Koa, Natanago, Jason Deen, thanks for the intro, and thanks for the opportunity to update you all about the UW Medicine Center for Indigenous Health. Kind of approaching health inequities from a little bit of a different angle than direct clinical care. So just goes to show that for those of you who are interested in health inequities, they're combating health inequities. There can be a multifaceted approach. Sorry. Okay, no financial disclosures. I'm a med-peds person, so that really shapes my worldview about how I approach health inequities. So for those students out there who love medicine but really like peds as well, please get in contact with me. So Indigenous health inequities have persisted in this country since contact. Colonization really led to a change in worldview about how about what defines health and how medicine should be delivered. So these health differences have really persisted for more than 500 years, and the colonization really set in place an abnormal political, social, and economic context for Indigenous communities in this country, which elaborates social drivers of health. So underlying systemic racism is the ultimate etiology for all health inequities seen in all marginalized communities in this country. Perversely for Native communities is they have entered into a trust relationship with the federal government for healthcare. This was codified in treaties that were established early on in the 1700s and 1800s. So not only does abnormal socioeconomic and political context or systemic racism dictate the etiology for these health inequities, it unfortunately dictates the responses to them. So the Indian Health Service, which is the federal healthcare system for Indigenous communities, is the least well-funded of all federal health programs, for example. So this is borne out in disparity, so measurable differences. These are mortality disparity data from the Indian Health Service. So the American Indian Alaska Native rate is the first column. All U.S. races is in the second, and then a ratio in the third column. So you see here that anything over 1 is more prevalent in Indigenous communities. So you can kind of go down the line here. Cardiovascular disease, accidents. So we just heard about diabetes, alcohol issues, COPD, CVA. I mean, just kind of going down the line. So it's worth remembering that health inequities really have deep roots. And the health inequities are from systemic racism. So in specific to Indigenous populations, I kind of mentioned this, but colonization led to different social conditions, different political conditions, lower socioeconomic status, which has set up power differentials between Indigenous communities and other communities in the United States. So again, that's the underlying, that's the root of the problem. These have led to things like, again, just structural racism, structural barriers for health, institutional barriers for health, different distribution of resources. We talked about the underfunding of the Indian Health Service, various forms of sexism, ableism, classism, those sorts of things. These in general elaborate adverse social drivers of health. So socioeconomic status, your built environment, your neighborhoods, educational attainment. So these in turn will affect, so I will add adverse childhood experiences here. These in turn affect health behaviors with the adoption of health adverse behaviors, which leads to differences in health outcomes for a lot of Black and Brown communities in the United States. So I think this figure really demonstrates the difference between a health disparity, which is a measurable difference in health outcomes, with a health inequity, which is more of a structurally based difference. Because we can so say I'm a cardiologist, so say cardiac disease, if we make the fruit of this kind of noxious weed, if we make the numbers look okay for say the Yakima Nation compared to the general population in Washington State, and we make the incident cardiovascular disease look okay. I mean, we have kind of pruned this tree a little bit, but it really hasn't killed the root of the issue. So while we can futz the numbers and make disparity less apparent, it really doesn't change the underlying structural barriers that lead to health differences for Black and Brown communities. So we are academic physicians, and we have a medical education responsibility. So a way to combat these health inequities is just to train more Black and Brown doctors. Train those folks who just look like the communities they're going to serve. And what's known is that all BIPOC folks, but specifically underrepresented medicine physicians, they're more likely to be involved in EDI work. They're more likely to serve their home communities or like communities that share culture. They're more likely to do health disparities research. So. And then, there's some direct kind of patient-facing things as well. This study was a couple years old now, but what it showed was that patient and physician racial concordance really was associated with improved outcomes. So improved patient communication, lower healthcare expenditures, improved outcomes for patients. So this is, again, this is a method to combating these health inequities that we talked about. For what it's worth, we need more Black and Brown doctors. We kind of know that. These are AAMC data from a few years ago now. So if we want to look at the American Alaska Native slice, it's 0.3% of all active physicians in the United States, and Native communities, the Native population is 0.2 of the U.S. Census. So quite a big difference there. In academic medicine, it's equally as stark. If you look at all Native folks who are in academic medicine, we only comprise about 0.4% of all academic physicians. And there's a big stratification by academic rank as well. There are currently 37,000 full professors in the United States, and 37 of those are Indigenous. So literally these folks are 1 in 1,000 physicians. So I'm very proud to say we have 3 here at the University of Washington: Dr. Terry Maresca in family medicine, Dr. Shaquita Bell in pediatrics, and Dr. Jim Jarvis in pediatrics. So again, these are kind of rare birds. We need to kind of cultivate an ecosystem that not only increases the amount of Black and brown doctors, Indigenous doctors, but foster their interest in academics so that it can feed the cycle. So, so we've learned that Indigenous communities in the United States experience significant health inequities due to colonization, ongoing systemic racism, which elaborates adverse social drivers of health. And again, a method to combat these inequities is to train health professionals from these under-resourced or marginalized groups. I will say there's quite a big shortage of Indigenous physicians, not only nationwide, as we kind of learned, but in Washington State and in WWAMI. So it brings us to the Center for Indigenous Health. We started this last summer. We are a community-facing center. So we have community partners. We partner with local tribes, not only in Washington State, but all throughout WWAMI. And we have a community advisory groups to ensure that we're doing the right things for the communities themselves. So again, that's a very important aspect of things. Not only in ecosystem building programs like the Center for Indigenous Health, but clinical care programs, research programs, and those sorts of things. A little quick a quick slide about our logo. So Mr. Fernandez, Roger Fernandez from the Lower Alwa tribe, he's Klallam, redid our logo. This current iteration of the Center for Indigenous Health is a continuation and expansion of a Center for Native Health Excellence that was present at the University of Washington in the late 90s, early 2000s. I'm the product of a similar program at the University of Minnesota, but so we updated the logo, and I'll just kind of read what Mr. Fernandez wrote. But, he said this logo is based on the concept of the basket and the ancient symbology found in Puget Salish basket designs. So a basket is a weaving of many diverse elements, tree bark, grasses, and roots, and these different fibers are woven together to create a harmonious whole. A container that can hold medicine, food, tools, clothing, and supplies. Just as our work can be made of diverse ideas and elements that create a container for knowledge, dreams, and ideas and wisdom. And that each of us is made up of many diverse elements that define us, our thoughts, values, philosophies, and beliefs. In this design, there are plant designs that cause us to reflect on the use of plants and the teaching they can build us, they can bring it to us. Belief of the elders is that the plants are our greatest teachers, and all knowledge we need to live in the world is in these plants. So these designs are ancient and woven by our Coast Salish ancestors for millennia and passed down to us. Much of traditional Indian medicine is based on plant medicine, community building, relationships, those sorts of things. So we thought it was important to represent that. Commonly, medicines were gathered in a basket like this. The rectangular figure that you see in the central kind of design is Devil's Club. Devil's Club is a powerful medicine plant, not only found in Washington State, but throughout WWAMI. So it's important to the Coast Salish people and Alaska Native communities and tribes out in Montana and through Idaho and Wyoming. So I thought it was important to represent all of WWAMI. we're pretty thrilled with the design. So the objective of the center, like I said, it's a community-facing ecosystem building program, but it's to increase the number of Indigenous physicians practicing in Washington State. So this is a picture from one of our traditional blanket ceremonies a couple years ago. Some of you may have attended our blanket ceremony for our Indigenous medical students. It's this Friday if you all are around. But these were all of along with some Native faculty, all the Native medical students, wearing blankets. I think these folks are second-year residents. Most of them stuck around, which we were pretty thrilled about, and chose University of Washington for residency. So our center is committed to several things: increasing the number of Indigenous students trained by our School of Medicine. We want to bolster support for current Native medical students, residents, and fellows, really all learners touched by UW Medicine, to ensure their success while fostering a sense of community and belonging at UW Medicine. And then, I thought it was important to grow a multi-tiered support system for Indigenous faculty at UW Medicine to guarantee their academic progression through their respective tracks. I've always thought the best way to recruit Black and Brown learners to an institution is to have well-supported and happy faculty. It's really hard to do the reverse. If we recruit, say, a Native person into our School of Medicine, but we really don't have Native faculty doing, usual academic stuff, once they get here, they find that there's a lack of support, a lack of understanding about them. I've always felt that, Indigenous faculty that are supported, academically productive, supported in their teaching efforts, doing wonderful clinical care, their reputation precedes them, and it trickles down, and learners want to come to those institutions. So after a few rounds of not getting HRSA grants for this program, I got frustrated. So, speaking of systemic racism, HRSA opened up funding for centers of excellence, URM centers of excellence cross country, but only allocated one center for Indigenous health. So even though we got fundable scores twice, we were not funded. So based on mentoring I got from Dr. Leo Morales, who's also in the department, we approached the Washington State Legislature. This is Senator Claudia Kaufman in Lower Wright hand corner, who is our state sponsor for our appropriations bill. So we got perpetual funding, appropriations funding through the Washington State Senate. So we are, since I have a dual academic appointment, but the center's administratively housed within the Department of Pediatrics. So we live on the third floor of the RR wing. So please come find us. We have a student space, administrative office, and my office is here. So please, it's just two floors down from the department's main floor. So our current team is me, Ms. Mila Kennedy, who's a tribal attorney. You see her here along with Senator Kaufman. She's our program manager. She helped stand up the previous iteration of the center in the 90s with Dr. Wathalla, who is the first Native graduate of the School of Medicine here. Cole Kadam is here in the purple. He's our program specialist and focuses on pre-medical recruitment. And Nicole Bay is our newest recruit. She's our administrative assistant and really keeps us on task. These are two of our current medical students. Shelby is a nascent third year, and Dejoni is a first year student. They're both Dene. This was at the American Indian Science and Engineering Society conference. We were doing some pre-medical recruitment there. So the big buckets of the center are focused on specific type of learners: pre-medical learners, medical students, GME learners, and then faculty, junior faculty in specific, with the expectation that senior faculty within the center senior Native faculty will then feed back into the system and act as mentors. So our pre-medical programming is really focused on strengthening the relationship. Again, we're a community-facing program, strengthening relationship with tribal communities, tribal colleges, and community colleges. And one thing I do recommend for folks who are thinking about similar programs is we had some of these relationships that were based on personal relationships in the past, and then when leadership changed, either at the university or these organizations changed, unfortunately the relationship languished. So we've been going through a relatively painstaking process of creating formal legal MOUs, memorandums of understanding, between us as the academic center and the tribes as a sovereign governmental, their own nation, basically. So it's an academic to governmental relationship. So in theory, this is a bit more longstanding. We'll have to see how this goes, but it's definitely appreciated, and it works to regain or bridge some of the mistrust. Because remember, all Black and brown communities, because of systemic racism that's perverse within the medical system, particularly the academic medical system in the United States, they do have some mistrust of us as a ivory tower tertiary center. So I think that this respects tribal sovereignty, respects governmental sovereignty, and it really begins to bridge that gap a little bit. We also want to increase the participation of Indigenous pre-medical students in the Office of Healthcare Equity's pathway programs. We have our first Native specific Doctor for a Day program happening this Saturday, and this is for tribal middle school kids and high school kids who are interested in medicine. So it's just one of the things that we're kind of helping with. We collaborate on a pre-admissions workshop with Oregon Health Sciences University. These are specifically for Native college students or post-bac students who are actively applying for medical school. Remember that the amount of professionals in Native communities is quite low. And again, this is due to structural racism. The high school dropout rate in some communities is above 70% in Indigenous communities. So naturally, that leads to a dearth of professionals in some of these communities. Because that's the case, we have a high population of Native college kids who are first-generation college participants. So therefore, the mentoring piece is a little bit lost with them. So we actively help them apply, talk to them about how to pay for it, talk to them about their personal statements, edit their personal statements, do mock interviews, the whole thing. And then my hope is that eventually we'll increase the number of Indigenous matriculants at UW School of Medicine. This is one of our pre-med mentees. I think our pre-med mentee list is around 50 currently. With some of the outreach we've been doing to conferences. This is Alessandra. If you can kind of read what this says, this is way over my head as a cardiologist who has just a simple plumber's mind, but she presented this work at the American Indian Science and Engineering Society. So he's currently applying to college. Hopefully we will get her here for medical school. So. We also have medical student and resident fellow support. We do several things in this regard. I think the biggest thing is we show the kids that we're there for them. We mentor them. We create community for them. We also give them money, which is good. So we have an active chapter of the Association of Native American Medical Students, A&Ms. So we provide them a budget to do things that they would want to do. So they had a powwow yoga session. They had a community dinner, and they've been sending each other the conferences. So we've been letting them dictate what to do with those monies. We also not only want to create a mentor sphere here at the University of Washington, but we also want to create a national mentoring circle for them. So we send them to Indigenous related health conferences, Association of American Indian Physicians Conference. the Pacific Region Indigenous Doctors Conference, the International Meeting on Indigenous Child Health, so all those sorts of conferences. The Native medical students have their own study space down here in third floor, our wing. We do have a Native health curriculum through the Office of Healthcare Equity, and we work with the Indian Health Pathway very closely to increase opportunities. So not only didactic opportunities, but clerkship opportunities for Native students. We provide USMLE prep materials and courses for those who have failed the step one. We augment student research as well through a small grants program, a little bit more on that later on. We sponsor visiting Native professors so that, again, they see these, that 1 in 1,000 Native full professor who can talk about their research, clinical work, and teaching. We're also doing a local mentoring program. So we assign one Native faculty member a cohort of Native students, and it's a situation where they just keep in contact with them. If they're having issues, they can refer those folks to the center so we can elaborate our resources and help them out. Naturally, we have a blanket ceremony at the end of the year to celebrate them. Honoring a graduate with a blanket is a way of caring for them, of showing that even though they're leaving that program, maybe even leaving the institution, that they have us literally wrapped around them, and then they can take us with them to greater and better things. These are some of the pictures from some of the activities that we've done for the past year or so. The top picture, Shelby, we already saw a picture of her. It's acultural for many Native tribes to touch dead folks. So she had the Pinkhams, Glenn and Yvette Pinkham, who are the traditional healers that are most associated with the Center for Indigenous Health, come in and bless the anatomy lab. So that was that. The middle two pictures are from the American Indian Physicians Conference in San Diego this past year. We do table at all these events and recruit heavily at all levels, whether they're pre-medical, medical student, GME, or faculty. These are some of our students that went to the conference. And the bottom picture is, I think this was at ACES. We had a panel for medical students, and they just talked about their experiences or challenges of being an Indigenous person. Please note that most of our students are female, so that's been good. But we want to make sure that everyone's supported to get into school. So currently we have 39 Native medical students. We admitted 11 to the incoming class of medical students. So hopefully we'll get all 11 of those. For residents, we have 13 Native residents, 2 Indigenous residents in the medicine residency, Nicole Nakamatsu and Michael Mena. So we're very, very proud of them. So we're, small but mighty and hopefully growing. I've really focused on faculty support, making sure that especially junior faculty are supported. These are just a smattering of the Indigenous faculty within the center. We currently have 15 Native faculty, and if we count affiliated faculty, we have about 25 Native faculty members. These are all academic tracks, from physician scientist, clinician educator, and we have quite a few clinicians in the center, and all different specialties: pediatrics, family medicine, anesthesia, family medicine, PM&R, and quite a few concentrated as junior faculty members. I think I'm the only mid-career person, and we have, again, 3 full professors. So the center has a small grants program that gives pilot funds or startup funds to faculty members. This is this smaller picture in the middle is Dr. Ray Mokiao from the Department of Pediatrics. She's in the division of nephrology. She is Native Hawaiian and Samoan, and she studies chronic kidney disease in Indigenous communities. She worked with our study, Strong Hearts, when she was a fellow. But we gave her some money to do a needs assessment for the local Native Hawaiian and Pacific Islander community in Seattle in regards to their healthcare needs, with a bent towards kidney disease in youth. She completed that survey project, and she's using those data to write her K right now. So we're very, very proud of her. The second recipient of the Small Grants Program will be Celeste Colgrove. She's Tlingit from Alaska, and she's a second-year OBGYN resident. She is what she wants to surveil the local urban Native community here in Seattle about their experiences with infertility treatments, and access to care for infertility. So that'll be her resident project. So just a smattering of examples. I also want to fund their whatever their interests are. If they're not a researcher, they're I want to make sure that the other parts of their career are supported, whether it's having them attend leadership conferences, whether we pay for them to do the Teaching Scholars Program through UW. We fund their opportunities, whatever is salient to their careers. We definitely the center definitely wants to support that. In that vein, we partner with the UW Medicine Academic Affairs Office through initiatives through like the CERP program and CMFA. So, and we're in the process of developing a summit for all Indigenous faculty through our area, just so we can not only create opportunities for Indigenous faculty, but create some sense of community with us as well. All right, so coming to the end here. So future directions for the center: since we have Washington State appropriations funding, we plan to go after monies to extend this programming formally throughout WWAMI. Again, I want to attain MOUs in all Washington State federally recognized tribes, so we can, my program manager Millie is a tribal attorney, and she works with tribal attorneys at the specific tribe. So it's a months-long process to get these MOUs. So we usually can do a small handful of the 27 tribes per year. I'm going to continue to recruit innovative Indigenous faculty. Dr. Jim Jarvis was our newest recruit. He's the inaugural endowed professor in Native American Health through Family Medicine. He's a pediatric rheumatologist, career physician scientist, has had 30 MAH grants. So of course he was a humongous boon for our center and UW Medicine in general. And again, my hope is that having national facing supported faculty will lead to more medical students coming in, will lead to more folks who want to train with us in our residencies and fellowships. We're working on an Alaska Native specific healthcare foundations track for Indigenous and allies who medical students who want to work with Indigenous communities. So this will be based up in Alaska, where they can do all 3 or 4 of their core rotations, foundation rotations within Native clinics and hospitals up there. We have formed our community advisory group, so we've met a couple of times. So again, all of our activities are community facing. It's not that me as the person who helps direct the center, or Millie, who really is the boss of the center. It's not really what we want. It's we focus on what the community wants and what they think would be helpful. I do want to partner with not only with Washington State University, but the osteopathic school near the Yakama Nation as well, just to make sure that we just get more Native kids into school somewhere. And then we're going to do some office space renovation eventually. So I want to say Nita Nitaki, thank you in my Blackfeet language for your attention and your interest in this. I think that this is good. This is useful information for especially department leadership or division leadership, as well as those of you in GME leadership, because this can be used as a recruitment tool for, Indigenous fellows or residents into the medicine program, fellows into a wide variety of our wonderful fellowships here. And then, of course, we would love to have more faculty join us as well. So, again, thanks again for the attention, the opportunity.
A big thank you to both of our speakers today for your excellent and thought-provoking presentations. We do have a few questions in the chat, for just a few minutes left, so we'll see how many we can get through.
Sorry.
No, thank you for your presentations. And so our first question will be for you, Dr. Deen. The question reads, one problem I've noticed is that academic centers and universities talk about diversity, but don't have the resources or systems in place to recruit and retain diverse physicians. How can we get buy-in from these institutions to promote diversity? It's clear that the culture needs to change, but what would be some actionable steps to do this?
Yeah, thanks. Thanks for the question. It's a great question. We need buy-in from leadership. So Tim Dalitz is an ally, and he knows the importance of this stuff. I mean, that's the primary thing you have to have. We have to have buy-in from Tim Dalitz and Barbara Young and all the division heads in medicine. And we need to have a shared notion of the importance of diversity. Only then can we have resources, which is money, only then can we have money for these programs. This is made all the harder by the challenges to affirmative action. Naturally, it's this is defined exactly within our academic institutions, and it hasn't really crossed over to GME programs yet. However, we just need to be very exact in what we're asking and how we ask it to these students. That problem is a little lessened by the fact that Indigenous students it's not a racial class, it's a political class, so we can still be very aggressive with Indigenous students, but for other folks, we need to be more nuanced talking to our lawyers. But it's really you need buy-in from leadership. They need to belly up to the bar and put money down for these programs. I mean, that's kind of what you need to do.
Thank you, Dr. Deen. And one question for you, Dr. Casas Wright. How have patients found the Latinx DM clinic? Has it been through word of mouth or reaching out to FQHCs? How's it been?
Yes, it's been by word of mouth. When we founded the clinic, we sent letters to primary care providers about the clinic. I think we should do that again. And then when patients are referred to the Diabetes Institute, then they are triaged and then scheduled in the Latinx diabetes clinic.
Great, thank you. We are unfortunately out of time, and we had several other questions. But a very big thank you to both of you, Dr. Casas Wright and Dr. Deen, for your excellent presentations, and for everybody in attendance today. This concludes today's grand rounds, and we'll be back in a couple of weeks on June 7th for our next presentation. Thank you, everybody.
Bye. Thanks.
Thank you.